mention these. And depression is surprisingly common in stroke survivors. The best estimates of it come from work by Marie Hackett, who's a clinical psychologist working in Sydney. And probably about, if you take a typical population of stroke survivors, about 1 in 3 will develop depression or depressive symptoms in the first year. And on average, you do worse if you develop depression. Perhaps not surprisingly, it's more common in people who've previously had a history of depression, and it's also quite difficult to diagnose. It's a group of people who've had a terrible life event often. There's often a lot of unhappiness and frustration. It's often very difficult to take a history because of language problems. We are, in my experience, we're frequently starting antidepressants because somebody who's aphasic is just not as alert and engaged as we would expect, and you're often got this rather limited information. I think the place of drug therapy and psychotherapy is not fully worked out, but most people would use the modern antidepressants, the SSRIs, if they were suspecting depression. A related problem is anxiety. Now, we don't often ask stroke survivors about anxiety, but there is often a chronic underlying anxiety which doesn't appear to be related to the severity of the stroke. It overlaps with depression, so it's a coexistent condition. And if you delve further, people who are not going out after the stroke, there's often a kind of agoraphobic element as well. And the best treatment here is unclear. Many of the SSRI antidepressants are also anxiolytic, and that's probably what we use most often. Emotionalism is part of this sort of triad of neuropsychological complications, if you like. And again, those of you who are working every day with stroke will recognize this sort of uncontrolled crying or laughing, usually crying. This is very common early on. It usually settles over time. And it's often a distressing feature. And occasionally we find it interrupts rehabilitation. It seems to be different from depression. Obviously, tearfulness is common in depression, but true emotionalism seems to be slightly different. But the management here that we tend to follow is firstly to try and explain that it's a normal feature of stroke. They're not going mad. That it normally settles of its own accord. But if it's distressing for the patient, then we often start antidepressants. Citalopram is the one I use most often, and amazing, it responds very quickly to antidepressants. The frequency of crying episodes, tearful episodes, and it responds more quickly than depression does, so it seems to be something different. But I think it's something that's worth trying to sort out what the individual would like you to do. Post-stroke fatigue. Now, I mentioned this briefly a moment ago. This is one of my great professional failures because many years ago when we started a follow-up clinic for stroke patients, I was struck by the number of times people would come in and say, oh yeah, I'm doing well, I'm really good recovery, I'm back at work, but I'm absolutely exhausted. And I thought, gosh, that's odd. And several of us commented on this and academically did nothing further with it. But lots of people have stepped into the challenge, and there's quite a lot of research going on in this now, and probably about half of stroke patients at least will comment on fatigue if you ask them. And nobody knows what causes it. It's not explained by depression. There's no proven treatment. It probably reduces over time, but we still don't really know that. And I know certainly in Edinburgh in Scotland there's a group looking at graded exercise as a treatment for this, exercise classes, but we don't know if it works, and there's trials I think being planned right now. The last sort of specific complication I'd like to mention is pain, and this is surprisingly common. This came as a surprise to me when we did our study, and our research nurses were checking at a sort of weekly basis how many patients had pain that required analgesia. And we were expecting to see shoulder pain as the big problem. And this was done about 10 years ago, before stroke units were in our area were opened. And we found that shoulder pain was happening, but and for a long period after stroke. But there were a whole load of other causes of pain that were much more frequent. And when you delve into this, firstly, it was more common with more severe strokes. We at the time in this study we used the FIM score, but so if people with milder activity limitation had a lower prevalence of pain compared with those with more moderate and severe. And the causes seem to be, well, there are multitude of causes. And I'll just go through the ones that were most frequent. But if you look into the literature, there's a whole load of different causes of pain that have been described in stroke survivors during rehabilitation. And then I'd like to just maybe put a little bit of time on each. What I wanted to do was just for each one very quickly say, well, the general approach that we tend to take is to be aware of the risk of pain, to try and identify the cause. And I think both of these require a multidisciplinary team who are really alert to the possibility of pain and the various causes, and then a management plan that covers a whole range of things, from good nursing care, physio interventions, and specific drug treatments, and treating associated problems. In our population, when we studied it, the commonest one was various musculoskeletal pain, and probably osteoarthritis was the commonest. And the assessment was, very much a multidisciplinary one, and there were a range of approaches. We would use the standard sort of analgesic ladder, starting with very simple ones, going on to more potent. People with very specific problems, for instance, osteoarthritis of the knee, we would often involve a rheumatologist. If people need, say, a knee injection. And also just to remember that pain symptoms seem to be worse with depression, so if you're treating depression, that often helps in the management of pain. Second one was shoulder pain, and of course I'm sure this audience are well aware of the risks of shoulder pain in hemiparetic stroke patients, and this is an area where I think it's become less common with much better team care in terms of lifting and handling, and support of the arm, a paretic arm, when somebody's at rest. And I think that the treatment, again, you'll be well familiar with this, recognizing there's multiple causes of shoulder pain in stroke patients, and there's a whole series of strategies that are worth trying. I don't think there's one that stands out as clearly dominant and superior to all the others. Another category was spasticity, and again, this is something that often makes pain and discomfort worse. Quite common in stroke survivors. My feeling is, again, I don't think we're seeing such bad problems of spasticity as we were 10 or 15 years ago. And I suspect it's down to better team care, better positioning and handling, and a better awareness of all the things that can make spasticity worse in terms of pain, poor positioning, low mood, and these are all things that can aggravate the problem. In terms of our strategies, usually most of what we do is in this category of things that we're really not sure if they work, but they seem to be, they're seen as good practice, which is around sort of good seating, good positioning, good limb support, and to be honest, we don't often use specific drug therapy, but we do have I personally don't do Botox injections, but we do have access to a service that will do this for people with very specific focal problems. And as for the more systemic drugs, I think we're just not sure how good these are. I mean, baclofen certainly works, but it makes you fall asleep, as does diazepam. So they're not terribly easy to use. Central post-stroke pain. This is the one that we always worry about. Unfortunately, it's not that common. And if you come across it, you'll be aware that it's frequently, people sometimes have very bizarre symptoms. Doctor, I think I've got an animal crawling inside my arm, or I've got paresthesia, or numbness with discomfort and pain. Really odd things, and occasionally people think they're going off their head. And so there's an element of reassurance involved, but the specific treatment can be quite difficult. We usually try a simple analgesic at first, and it usually doesn't work. And then your mainstay is really tricyclic antidepressants and anticonvulsants. Occasionally, we refer people on to specialist pain clinics because of really intractable problems. It's a horrible neuralgic pain in some people. And again, to be aware that the depression definitely makes these symptoms worse, and so it's about treating the whole patient.